So it's a very proud feeling for me to come back after 8 years and present. So now I'll start with the treatment of endophthalmitis. So these are the topics on which I will speak. So as we know, endophthalmitis requires very timely and adequate management. And same day intravitreal antibiotics is like legally and ethically binding to every eye surgeon. Because same day PPV, though it may be gold standard in some cases, it may not be easily available. So any presentation on treatment of endophthalmitis starts with EVA study and the 4 major recommendations as I have shown. But you have to understand that over the years, the treatment protocol has slightly changed. However, microbiological evaluation in all cases and intravitreal antibiotics hasn't changed. However, the choice may have changed. So what knowledge has been added in the 3 decades, as already explained in many presentations before, that we have recognized that there are more cases of gram-negative endophthalmitis here, more cases of chronic endophthalmitis, culture-negative endophthalmitis. Now, as you all know, anti-VEGFs have surpassed cataract surgery as the most common surgery, ocular procedure worldwide. And there are trends of ceftazidime resistance in southern parts of India. However, there have been advances of vitrectomy surgery for diagnostics, and with the advent of moxifloxacin, we have seen that systemic antibiotics do have a role even in post-cataract, post-surgical endophthalmitis. As Madam has said about the landmark Irvine study, so we have good prophylaxis. And also, as the procedures have increased, we have been able to risk stratify and know the incidence and prognosis of each type of post-procedure endophthalmitis. This is uh, not a absolute protocol, but only vision should not be the criteria of choosing vitreous tap or vitrectomy, and systemic antibiotics and steroids have role. So coming to vitreous tap, still it's a standard procedure because it's technically easy. Minimal instrumentation can be done in any setup, where it's private or in a like clinic setup, you can do that. Preoperative USG is helpful for diagnosis and planning of the site. Point one, I'm not going into details because there is a workshop there in the afternoon, but I want to stress that 2 ml or 5 ml syringe is important because the suction needed is more so that dry tap doesn't occur. And we give intravitreal injections with a 30 gauge needle. And obviously it's spoken of about the culture and gram stain, but PCR and backtech are useful to get more positivity. And post-procedural scan is obviously required for monitoring and any complications. So these may be the complications, dry tap, IOP related. Sometimes if there is any like vitreous traction in the wound and all, it may result in retinal breaks and detachment in future. And hypotony related serous or hemorrhagic detachment, choroidal detachment may occur. And as Naresh sir had said, that there are cases of drug toxicity causing retinal ischemia or foveal thinning. So what do you do when there is a dry tap? Dry tap actually occurs if you do not reach the liquid vitreous or the vacuum is less. It's more common in young people. So alternatives are AC tap and aqua specimen. Just understand, if you don't get a vitreous tap, you have to concentrate more on other diagnostic modalities like PCR, or nowadays in some in foreign countries, next generation sequencing is available. Do inject even if it is a dry tap. And as Nagesh sir said, in endogenous cases, the yield is poor, but that is not due to dry tap on all. That is due to because the focus is mostly on the chorioretinal side. So you may have to depend on PCR and advanced technologies to get a good yield. So in another option is doing vitreous biopsy. So this is a recent paper 2025. We know vitreous biopsy is generally done with the vitrectomy machine and cutter without keeping the infusion on and by manual suction. Here they have tried to do in clinic vitreous biopsy by accentuating the cutter with manually. Like a assistant will hold the drive line, is 10 ml syringe, and will push slightly so that there is cutting and the surgeon will draw the fluid. I don't know, I have no experience on, I don't know will this technique will last in future, but this is another option to quickly get vitreous biopsy in OPD. The choice of antibiotics is very important. So just want to stress that EVS choices are not like it is not fixed in every region. There are alternatives, especially relevant in setup here in southern India, like piperacillin, tazobactam, imipenem, and moxifloxacin. And it helps to not only in individual cases to determine for the response, treatment response, but for also determining the empirical antibiotic policy. Like we had published this study in around 2015-16 cases where we saw a lot of, already we have seen that lot of pseudomonas cases occurs here, and there was resistance to ceftazidime, and we also got multi-drug resistant. So over the years, we have seen the increasing resistance to the conventional antibiotics. And it has been seen that if you replace ceftazidime with piperacillin or imipenem, there is no such retinal toxicity and it results in equally effective outcome. So this is the usual drug we give, which is put up in every OT, should be put up in every OT. Just want to highlight that when you give in silicon oil filled dyes, you have to reduce the dose and also try to know the preparation of the non-conventional second line drugs, which are more relevant here. So when to give antifungals, when you are suspecting some kind of fungal etiology, as in laced post-cataract endophthalmitis, keratitis or post-PK endophthalmitis, traumatic endophthalmitis, and in endogenous cases, mostly we give voriconazole because it has lower retinal toxicity. However, in endogenous cases, majority are candida and ampho work better. Finally, it's tailored to drug sensitivity and resistance. And regarding steroids, you may not give steroids in the initial first day if you are not sure of the etiology, but steroids do reduce the need for repeat intravitreal injections. And dexamethasone is the choice because it has a shorter half-life and IOP related issues are less. Regarding repeat, maximum generally 2 injections are given for 48 hours apart if some improvement is noted. However, ESCRS, there is a controversy regarding this. They advise early PPV in all cases. They consider that to be gold standard. And if there is no improvement, you should not delay PPV beyond 48 hours. So take home message, tap and inject as early as possible on day 1. It's still the gold standard. It's still the protocol we generally follow. Every ophthalmologist should be well versed with the procedure and calculation. Review of choice of empirical antibiotics can be done considering the area and drug sensitivity. More sophisticated diagnostic tools are required, and I will request everyone, every doctor, against injudicious and indiscriminate use of antibiotics and advocate them at all levels. Thank you.